The next concern or question, and Scott, I would throw it at you, is, the new Lublin criteria with inflammatory, active versus inactive, and the slides he has, which are excellent. But in my opinion, I think it's sort of added to the confusion a bit. And because, only the readers of the journal Neurology read it, and then it gets out there, and patients are saying, what am I? What's happening?
It's hard when you start slicing and dicing things too much.
That's right.
I think in my view, and I'd certainly like to hear others' point of views, is that, when we're looking at MS, regardless if it's relapsing or progressive disease, at least from the clinical standpoint in making treatment decisions, at least in my clinic, I'll really leverage a lot of my decisions on inflammatory activity or not. And again, regardless of where you are in terms of the subtype. So where I think the guidelines are very helpful is the MRI guidelines specifically is, goes back to, okay, is there inflammation present or not? And if there isn't, then you have to step back and say, okay, what are we going to do treatment-wise? Am I going to escalate treatment, even in the context of someone progressing clinically at the bedside? Especially with the newer therapies that we have that have indications for progressive MS. We have to always think about safety in mind with our patients, and so some of the newer drugs have, quite a bit of baggage with them. So I think it's, again, nice to have, these subtypes and slicing and dicing and categorizing people, but when it comes to disease-modifying therapies, we have to look at, okay, is there inflammatory activity or not? And I think the MRI guidelines can help. I would say with the gadolinium topic that we've already discussed, that's where for myself it's a little more difficult, even in the context of someone who's had MS for a while. Maybe I haven't read a prescription to get contrast enhanced MRI, and then if I see them having some worsening at the bedside, that might be an opportunity to do another contrasted MRI if they hadn't had one in a while to see if there was reactivation. Because again, that inflammatory versus non-inflammatory. Yeah.
Well, you in Canada and Europe have a much easier time. We in the States sometimes will see authorization for an MRI. Only if you see activity, then you can use gadolinium. You've seen that, right?
Yeah, it's crazy. Very unusual. Like if you, I guess the point is, from the neuroradiologist side, I'd love to hear your view on this. T2 lesions that are new, they were enhancing at some point, right? It's just a timing of when you do MRIs.
You just missed.
You just missed it, right?
You just missed it.
So I can understand the point of, if you see a new lesion, doing a contrasted enhanced MRI after that. But it's a new lesion regardless.
That's right. And who's going to read it? Neuroradiologists or the not necessarily sitting there on site. So they're asking the technician who's doing the scan to
do the contrast.
And that is not realistic. Ideally, you would look at the scan. I agree. And if there's no changes, there's also no need to give gadolinium. But how confident are you? And in a real-time read at the monitor, not in your reporting room. I think that's a difficult one, and also will be obstructive in terms of patient throughput. If you, every time the radiologist has to come in the room, look at the scan, review them, and then decide to give gadolinium. And then, so if they don't, then suddenly there's an empty slot. Or if you have the next patient waiting, then suddenly you have to do the gadolinium scan. I don't think that's a workable situation.
I think one of the things that we've talked about at this meeting and also in prior meetings was really emphasize the point that communication between the neurologist and the radiologist in terms of requesting that study needs to indicate whether the neurologist is looking for current activity. If they're looking for current activity, then gadolinium is very important because it tells you that there is a new activity that has happened within the past 4 weeks. On the other hand, if what they're interested in is what's happened during the time from their last visit, say a year ago, whether there's been any new activity, certainly the T2 scan by itself is all that is necessary. It's not necessary to give a gadolinium examination. No. So the distinguishing feature is whether, from their point of view in terms of their deciding with the patient whether it needs to initiate treatment or modify treatment, whether that need to know whether the activity is ongoing currently or whether it's happened during that.
And that's why it's important to have, sufficient information on the request form, because
Exactly.
Yeah, that's-
Exactly.
yeah, quite often, to be honest, it says, monitoring therapy. Well, okay, so what is your goal?
Why?
And
Yeah.
if it's just a routine monitoring, the anticipated result is that it's negative, nothing happened, and then you can do that without gadolinium.
So
If there is concern about possible activity, or you're considering switching, put it on the request form, because that will trigger us to give gadolinium, and that's an important decision point.
Oh, I think that's a great point, because just saying MS on...
MS, monitoring,
340.
yeah.
Yeah, no, you're right. And maybe that should be in the printed guideline when we print it up. We should have a sample way of requisitioning the MRI, because that would help the clinician who is not exposed to this kind of information. I really think that would be something we should put as a high priority. It would sort of enhance our message.